Now, discussing the anatomical background and the physiological processes that can contribute towards the development of the comatose condition in the individual, we'd be focusing on the different organs or the different areas of the central nervous system that are basically contributing towards the development of this state of unarousal, state of unconsciousness, and unresponsiveness in the individual. Now we have the cortical regions, the two cerebral hemispheres that are basically contributing towards this particular development in the individual. Now the cortical regions, as we all know, we have the different lobes over there. For instance, we have the frontal lobe, the parietal lobes, the temporal, and then we have the occipital lobes. All of these are responsible for the different reflexes in an individual. Usually, the frontal lobe is responsible for the overall personality of an individual. We have the parietal lobes, in which we have the two major areas of speech that are lying over there. We have the Brodmann's area, we have the Wernicke's area, which is basically the motor speech area of the individual. So the comprehension of the speech is something which is done in the Broca's area, and the Wernicke's area, which is lying also in the parietal lobe, is responsible for the motor activity of the speech in the individual. So if there is some sort of lesion that is affecting the Wernicke's area of an individual, he or she will not be able to speak in all, either the speech would be affected partially, or it can be affected totally in these individuals. So having a complete knowledge of these cortical areas, all of these areas which are responsible for speech, or either the occipital lobe, for instance, which is responsible for the visual reflexes, is very important over here. There are primary visual centers in the occipital lobe, and if it is damaged, which is usually as a result of severe trauma, the coup and the Contacou injuries usually result in the damage to the occipital lobes or to the frontal lobes due to this particular mechanism of injuries in the coup and the Contacou phenomena, which are also known as the accelerating or the decelerating injuries that usually happen in the motor vehicle accidents. That can sometimes result in the damage to these primary centers and result in comatose patients. So it would be really depending upon the areas that are involved, the area of the cortex that are involved, particularly over here. Then we have auditory centers, auditory reflex centers in the temporal lobe, and that can be affected, and resultant effect can be produced. Again, it is going to depend upon the particular area that is involved. Apart from the cortex, we have thalamus, which is a major relay station in the central nervous system. If it is damaged due to any reasons, it can be trauma, it can be due to the mass herniations that can be produced in an individual. Again, it is going to result in the comatose condition in the patient. We have the brainstem injuries, which is again going to result, and it is going to affect the reticular activating system of the individual, which is lying over there in the brainstem. The nuclei are lying over there, and any sort of traumatic injury or state of infections or the metabolic disturbances can affect the activity of the reticular activating system, and in turn that is going to affect the sleep-wake patterns in the individual. So this is the whole mechanism for the development, and these are the basic areas which can be damaged under any kind of the pathology or the etiological factors that are contributing towards the damage of these particular areas, and obviously resulting in the state of vegetation or the comatose patient in particular. So we have different conditions. For instance, I've already focused on the fact that we can have the damage to the cortex that can be done. Then we have the reticular formation, the reticular activating system that is responsible for the arousal of the individual after a sleep cycle. And if it is damaged or if it is not functioning properly, that can result in a disturbed sleep-wake pattern and a lack of arousal in the individuals. Now, in the persistent vegetative state, which is a severe form of coma, we can have a damage to the cortex and cerebral hemispheres both. The ascending reticular tract formation is usually intact in these individuals. So when you look for the ascending tract formations or the sleep-wake patterns, they would be normal in these patients. And this is the highlight, or this is the differentiating point from a comatose individual and an individual in a persistent vegetative state. The prognosis is not very good for the individuals, even who are suffering from this vegetative condition. And that is why the word persistent is usually used along with this patients who are suffering from this vegetative state, because if this state prolongs for more than a year, the prognosis is not that good for these patients as well. Then we have a locked-in syndrome. We went through the basic pathology that there is an intact cortex in the locked-in syndrome and there is a damage to the ventral pons. Now, what does it mean when there is a damage to the ventral pons? All the descending tracts can be severed from here. And that is why the patient can perceive the stimuli, the patient can hear, and the patient can even respond by making the eye movements horizontally or vertically. And that is basically when you ask him, either you can hear me or not, he or she can basically perform eye movements and tell you that he can perceive or she can perceive the hearing, and the hearing is intact in that individual. So differentiating the patients of the locked-in syndrome from the patients of comatose condition or the patients of the vegetative states is very important. The prognosis is very good for these patients of locked-in syndrome when you treat them properly and when you know that these patients are particularly suffering from this condition. The ascending reticular formation is also intact for these patients. So this would be an entirely different condition that they would be suffering from. Then we have patients of a brainstem death that can occur. Again, due to multiple causes. We're going to learn in the etiological factors. The brainstem death is again going to result in the lack of the reticular activating system working properly for these patients, and again resulting in a disturbed sleep-wake pattern. The arousal would be difficult, the conscious levels would be quite low, the GCS would be less than 3 and less than 5, mostly on max it would be less than 5, and this would be quite a vegetative condition for the individual, and the lack of arousal, lack of unresponsiveness would actually prevail for these individuals. Now, how do you check clinically for the patients of the locked-in syndrome? You usually perform the pupillary eye reflex phenomena for these patients. And when they're lacking and there is a loss of reflexes for these patients, that is indicating the upper brainstem is involved, because usually the nuclei for these particular pupillary reflexes are lying in the upper brainstem. And that is why if there is a lack of pupillary reflexes, that is indicating some pathology in the upper brainstem. So again, the anatomical knowledge regarding the different nuclei, the cranial nerves, and the reflexes that they're going to perform, and how do you check for these cranial nerves is very important. The nuclei lie in different regions, and we should know that how are they exiting the base of skull, and that is again going to highlight the fact that what particular nuclei is involved and what particular region of the central nervous system is involved in this particular patient. And again, history is going to be collaborative for these patients, and you are going to basically look for the points in the history, the positive points, and again, you're going to jot down these points, and along with that, the physical examination is going to reveal a lot of factors. You're going to perform the complete physical examination, starting off from the general physical examination and moving on to the neurological examination. And then only you can decide the differentials, the differential diagnosis for that particular individual. And upon performing the lab investigations, you're going to decide the definitive diagnosis, the treatment guidelines, and the management plans properly for these particular patients.